Hi, my name is Mercedes Ekstrom, and this is my mini quality improvement project. I began my project by identifying a problem. The problem that I identified were there are avoidable errors being made by healthcare professionals during the discharge process from the acute inpatient units that are resulting in frequent return trips to either the emergency department and or readmissions to the inpatient units, all within the 30-day readmission threshold that Medicare has. These hospital readmission rates are estimated to be nationally at about 14% and account for approximately 52.4 billion in additional healthcare costs with varying reimbursement levels by Medicare. Believe it or not, this has actually decreased in recent years. Um, in my practice, I have witnessed some of these errors, including patients being discharged with lines that they were not supposed to be, whether that be a peripheral IV, a Foley catheter, patients being discharged without lines that were intended to be um, left in at discharge. A prime example of that, one I've seen unfortunately a number of times, is patients being discharged without a pick for outpatient IV antibiotics. So that causes them to have to return to the emergency department and be readmitted as an outpatient observation patient for just a couple of hours to get that line replaced. Um, I've also witnessed patients being discharged without proper supplies, equipment, or their prescribed medications. Um, as far as supplies, a lot of times it's like DME equipment. Um, I also have seen patients discharged without follow-up care being set up, whether that be with a specialty or just a general hospital follow-up with their primary physician. And then most often we see patient discharged without clear understanding of how to manage their care, how to take their prescribed medications, how to manage their chronic conditions. Um, all these things lead to increased likelihood of poor outcomes, and also unnecessary cost and utilization of resources. It takes away having a patient return to the emergency room for even such a small thing as removing a peripheral IV. Um, that takes away, that diverts resources that could be used on something else. This led me to the question of how do we reduce the rate of hospital readmissions from preventable errors that occur during the discharge process. The first thing I needed to do then was to assess cause and effect factors. This leads us to the fishbone diagram that I made. This assists with um, assessing root cause analysis, looks at all the possible causes of the problem, examines factors such as people, processes, equipment, environment, and management. As far as um, people as a factor, the items I identified were nurse fatigue, pressure from patients and family members to speed up the discharge process because we all know it takes a while. Improper education of the staff member on how to educate their patients, prepare their patients for discharge, um, what anticipating what the patient might need for discharge. Um, Another item was interdisciplinary miscommunications. There are a lot of people that have their hand in the pot And while this can be helpful by offloading some of the work, it can also lead to miscommunications on expectations, what's needed to be done, what has been completed, what hasn't been completed, and such. Um, and that also ties into the last point there. Too many people involved with tasks, and they're not designated tasks. As far as the process, patient discharge needs vary. Um, some are really straightforward and some are quite complex. Some people are discharging home, and that brings up a different set of needs. Some are going to a facility, and that brings up a different set of needs as far as discharge. Um, that being said, there is no standard process for discharge. There's a lot of pieces, and it kind of depends on each individual patient's needs. Um, there also is in the process a big push, and this could also go under the management um, factor, a big push to keep patient flow going to get that patient onto their next um, step of their journey to then create room, a bed for another patient. As far as the environment, um, primarily talking about hospitals in this case. So the environment is fast-paced. There are frequent interruptions. You have patients with all sorts of needs. Um, their status can change very rapidly. You might um, only see a doctor every so often. So then when you do see them, you're in the middle of something else. There's always just an abundance of interruptions, and it's sometimes hard to keep your train of thought. As far as management, uh, short staffing, that can increase the nurse's workload and contribute to their fatigue and the fast-paced busyness, interruption, those all kind of coincide there. Um, Relating back to process, keeping the patient flow going, there's a lot of pressure from upper management on the unit management to make the beds available to keep the flow going in the um, discharge process. And as far as equipment, the main thing that I identified was that there's no designated flow sheet or checklist in Epic. Epic is the computer program that we use at my facility, and there is a portion that has discharge items, but it's not necessarily a checklist. It's kind of redundant. It doesn't have a good flow to it. It's not something we're required to do. It's just kind of there as an added resource to find different pieces of information related to discharge. And this all relates back to the problem, which is the head of my fish there. That is hospital readmissions due to avoidable mistakes made during discharge. Next, um, looking at my problem, I was able to formulate my goals. So my projected outcome SMART goal is to um, have hospital readmissions due to discharge errors be reduced by 50%, so half, over the next 30 days. The specific outcome measures are to decrease the rate of hospital readmissions within 30 days of discharge. We will be reducing this by 50%, and the timeline is 30 days. I went with that timeline because that is the general Medicare timeframe for hospital readmission. Um, as we're doing quality improvement projects, research is a significant part of that. Finding evidence-based interventions to support the intervention that you choose. Um, Both of these resources identify discharge as being part of a continuous healing journey rather than the end of a journey. And this outlook is super important. We're not bringing the patients to their final stop. We're preparing them to continue on to this healing journey and be as successful as possible. Both of these articles also identify that this is a very critical and vulnerable time for the patient, and also a time where a lot of the errors do tend to occur due to um, problems with communication and coordination. Both of these articles do identify checklists of various forms um, as interventions to help reduce the rate of readmissions and also to reduce poor outcomes. The next portion of the quality improvement project is to identify evidence-based interventions. Um, you will notice that communication is a factor in all of these, and they are somewhat closely related, at least a few of them. Um, the first one is the teach back method. This is a communication technique that emphasizes closing the loop to ensure complete understanding. The next is a multidisciplinary approach. This specifically involves sharing the workload, establishing responsibilities, designating responsibilities. Um, the next is a very specific planning strategy. This is the ideal discharge planning strategy. This strategy begins at the time of admission. It works to anticipate and plan needs for discharge, and it includes both the patient and or their family as active members in the um, process. The next intervention is a discharge checklist. This is an organized, multifaceted approach to ensure that all tasks are completed and patient needs are met prior to discharge. This one has a little squiggly arrow by it because it is the one I chose to focus on for my quality improvement project. And the last evidence-based intervention is a multidisciplinary timeout. It is a method of communicating. It gives you a second to disconnect, to step back, to have multiple people looking at, um, in this case, the discharge and everything occurring during the discharge, gives you an opportunity to identify errors or remaining gaps in the discharge process. As far as implementation of the discharge checklist, what data can you collect that will show a change in the outcomes? Um, the data that I would examine prior to and reassess after implementation would be the level of readmission rates. Um, this would also be reflected in organizational fiscal reports and also patient satisfaction scores or HCAHPS. This one doesn't have a direct impact, but generally, if there are things missing in the discharge process, or patients don't have what they need, or don't have a clear understanding, then their satisfaction will be decreased. So, by doing all these things, having the checklist to cross all these T's, dot all these I's, that would better prepare the patient and hopefully increase patient satisfaction scores. Would you be able to pull the data from an existing source, or would you need to develop an additional source, such as a checklist? I decided that a run chart would be the best way to view this data. And this would examine the readmission rates over time. It examines existing data prior to the intervention. Um, and then we would later on reassess this after the intervention was complete. So that brings us down to the next question. Identify how you would display the data results to your leaders. Again, using a run chart to visualize the rates of readmission since implementing the intervention. And then the last implementation question, how might you gather the data you need in order to implement this project? Again, just getting a set baseline of things such as readmission rates, HCAHPS. I would also do some chart review and subjective interviews of some of the primary stakeholders, the patients and healthcare team. Implemental approval. To begin working towards implementing this into my practice, I would identify quality improvement team and establish roles here. So actually all of the team um, would be a stakeholder in some way. Um, but I would designate um, probably the nursing practice council on my unit and possibly nursing management as clinical leaders. Nursing management also has the authority to make changes on a unit base. Administration was who I identified to have authority to make changes on the organizational level. Next, presenting the established problem and intervention. I would work to clearly present and support the problem with data, identify objectives, provide evidence-based intervention, specifically propose the checklist, discharge checklist. And then I would communicate my goals and use specific indicators here. Combining all this, I would plan for implementing this intervention by outlining it to my clinical leaders and presenting it to unit management. Once this is done, we can begin our PDSA, starting with the plan due, a comprehensive yet concise checklist for discharge needs and tasks would be made using stakeholder input. This intervention would be communicated, I believe most efficiently would be at daily huddles. On my unit, these take place at 1500. The checklist, once produced, would be made readily available to all nursing workstations. And then the Nursing Practice Council would be a good person as the leader to do elbow-to-elbow communication on the intervention, kind of more that one-on-one communication to help with implementation. And then here, while we're implementing, I would start to collect data. This data would then be viewed further in the next portion, the PDSA study/act portion. On top of the data collected, feedback would also be collected. These findings would be presented to upper management and administration, which then ACT would come into play where we choose to adopt, adapt, or abandon the intervention. If the intervention is found to be successful, then adopting would be in order. This would mean that the intervention would be implemented into standard unit practice. And at this point, I wouldn't be done. I would advocate to implement the checklist in some form to an Epic flow sheet as a required documentation task that generates when discharge orders are placed. If the intervention was not to be successful, then it would be adopt or abandon that we go to, reassess the intervention, see what can be made better, keep trying by repeating the PDSA cycle. By doing this, it promotes continuous quality improvement. And here are my references.